How do you test the posterior glenohumeral instability? Dislocation of the shoulder is a favorite topic. Apprehension test, many times it was asked in the past 15,000 question bank. No big deal about it. But some named tests is what we have to be sure. If you want to check anterior stability, what you should do? Drawer test. If you want to check posterior stability, what do you want to do? And a multi-directional instability, what you want to do. Now let us quickly examine each of these tests. We do a relocation test where the patient is in supine position, the shoulder is abducted and externally rotated using the edge of the table as the fulcrum, and if there is an anterior instability, there is an apprehension. Then similarly, if a caudal traction is applied to the humerus in an attempt to displace the humerus inferiorly, then apprehension will come. It is called sulcus test. Then you call drawer test, where the examiner pushes the humeral head against the glenoid fossa and then moves it anteriorly and posteriorly, and this is to know the anterior displacement. Then finally you have a jerk test, and the jerk test, the patient's arm is abducted at 90 degrees and internally rotated, and it is typically positive. It is a posterior-inferior instability of the shoulder joint. So that is how you conclude the answer as what is the answer? Jerk's test for the posterior instability. Metaphysis is the most vascular part of the bone, hence it is the site of the osteomyelitis. There is a pain in the arm, wasting of the muscles after the tetanus vaccination is a classical nature of the brachial neuritis, which can have an acute onset with the arm weakness, which is more proximal than distal. Sensory and reflex impairment will be there with the history of tetanus administration. Kocher-Legenbach's procedure is what? Once more, I think examiner is obsessive about acetabular fractures this exam. So once more, in the case of the acetabular fracture, we do a posterior approach in order to fix the acetabular fracture, which is basically called the Kocher-Legenbach's procedure is what need to be remembered. Now this is a very interesting question. A 10 months old baby like this, who was previously normal, suddenly became sick, and all the other examinations are normal except hypoglycemia is there with him, and there is a hyperpigmentation classically. What is your diagnosis? This is never seen, never asked question in exam. 20% of paper will be like this. So we need to know familial glucocorticoid deficiency is a diagnosis and a syndrome in itself, which classically will have this kind of a story. Most striking feature in the clinical picture of familial glucocorticoid deficiency is excess pigmentation of the skin, areola, genitalia and mucous membranes. But what is important? There is no mineralocorticoid deficiency. That is the reason the patient will not have any hypotension or any other hemodynamic changes. They will all be normal. And there are certain findings before you label the diagnosis as familial glucocorticoid deficiency. What are they? There should not be ambiguous genitalia. If it is a congenital adrenal hyperplasia, then there can be a glucocorticoid deficiency, androgen deficiency, all of them can be together, and that can lead to development of a similar picture. So there should not be any ambiguous genitalia. There should not be a cutaneous candidiasis. Why? Because in polyglandular autoimmune syndrome, there will be cutaneous manifestations along with glucocorticoid deficiency. That should not be there. There should not be alachremia achalasia. Otherwise it becomes Algrove syndrome, where glucocorticoid deficiency can be associated with alachremia and achalasia. There should not be any neurological signs, otherwise it becomes adrenoleukodystrophy or Wolman's. There should know if there is a absence of adrenarche, it can be there in the case of the familial glucocorticoid deficiency is what need to be remembered. But generally, what is the otherwise favorite question of examiner? Every time he used to ask, by this time in May we used to discuss about dexamethasone suppression test, adrenal versus pituitary in Cushing's, but this time there was no question. Now hyponatremia and hyperkalemia, where do you have? Whenever there is any mineralocorticoid deficiency, aldosterone normally causes sodium retention. If it is not there, hyponatremia, sodium loss will be there. Potassium loss, if it is not there, potassium retention, hyperkalemia will be there. CPAP we give in preterms. to improve oxygenation and lung compliance, and for the infants less than 28 weeks, never give 100% FiO2, give only 25, around 50 to 60, otherwise you will be predisposing them to the neovascularization of the retina. Then it is never given prophylactically for that matter in preterms, it is given as a treatment rather. Now a child presents with hepatosplenomegaly with adrenal calcification. I don't know whether last row you are able to see the adrenal calcification. Adrenal calcification also is there. So it is a classical story in the case of the Woolmans, where they will have mental deterioration, hepatosplenomegaly, and intra-abdominal adenopathy, jaundice, anemia, and also adrenal calcification. A child has got macules, palpable purpura, is a feature of the Henoch-Conlin's purpura, which is one of the common questions in exam. Hypersensitivity vasculitis of Henoch-Conlin, which part of the vascular tree does it affect? It generally affects, pathology is there at the level of the post-capillary venules. In papillary necrosis, what is the radiological sign par excellence? It is the lobster's claw sign, which is the linear streaks of contrast in the papillary necrosis will give that this kind of a, are you able to see a lobster's claws in this in a case of papillary necrosis? Hope you are seeing that. Then ring shadows will also be another radiological feature, but I am not sure again spoon and track appearance. Maybe some of our, is there any, what is that? Again cup and not in spoon, okay. Okay, then it is something related to the clawing probably. Now let us go to the next question. In fact there is also a ball on T sign also, ball on T. T is the classical golf, so ball on T sign. Now which stain do we use to identify malignancy on endoscopy? It is the methylene blue which is used selectively, it will stain the intestinal metaplastic and dysplastic cells. Methylene blue is the one which is used in the chromoendoscopy. Annexin 5 is a marker of what? I was just searching for where is the question on apoptosis, because apoptosis there are some 50-60 questions in pathology. There are totally 800 questions. I will give you the classified list of higher priority to lower priority topics. Apoptosis is the 6th or 7th topmost topic in pathology. If you say I finished pathology but I didn't read apoptosis, means going to Varanasi and not seeing Parameshwar. So that is as bad as that. So we need to know that of course recently I went to Varanasi to see the Parameshwar. The only place where everyone touches Parameshwar, directly they will touch the god and come out. Whereas if you go to Madurai or any place, you have to be quite far from the Parameshwar. So your approach to pathology must be like meet Mr. Vishweshwar in Varanasi kind of an approach to most high yield topics, you should not miss. So annexin is the one which is an inhibitor of blood coagulation, because it will compete with the phosphatidylserine, and antibodies against this annexin are implicated in the anti-phospholipid antibody syndrome, and it is also very much implicated in apoptosis as a marker of apoptosis. Skip lesions are seen in Crohn's. Crohn's versus ulcerative colitis, one question, without that where is the paper? Then what is the cause for the aging and cancers? Once more, without telomerase there is no question paper at all. Many times we discuss this topic. So we need to know that if you take embryonic stem cell versus adult stem cell, what is the difference, doctor? As much a difference between a first year MBBS and a house surgeon. Telomere will be short in adult, it will be long, and for the telomere to be long, how should be the telomerase? Generally ACE means cut, no, but it is a misnomer. Telomerase, if it is active, telomere length will be long. Telomerase is short, I mean inactive, telomere length will be short. A short length telomere will make the cell become geriatric. House surgeons live in pessimism and first years live always in an incurable optimism, right? So it is the telomerase which is the differentiating factor, aging. So we need to know, doctor, that telomerase activation, if at all it occurs in an adult cell, that will predispose to the development of the aging and associated cancer is what I like to underscore to all of you, which will make the cell become immortal. How do you grade renal cell carcinoma? Is it histology or the size which is important for grading? Staging is metastasis, grading is generally associated with histology. So there is a Fuhrman's classification of nuclear grading of the renal cell carcinoma, which depends upon the histological, cytological features rather, based on which we grade the renal cell carcinoma. Concomitant hyperplasia hypertrophy is what you see with the uterus in pregnancy. What do you mean by metastatic calcification, doctor? High calcium levels, if they are there, they will go and deposit everywhere, it is metastatic. Normal calcium but deposits in degenerated tissues is dystrophic. So we need to know that metastatic starts in mitochondria, it does not occur in degenerated tissues, it does not occur in dead tissues, and the serum calcium is high in metastatic, not normal, unlike dystrophic, is the fundamental difference. Many times this was a favorite question. Then histiocytosis, lot of questions on Beer-Beck's granules, eosinophilic granuloma, Letter-Suvis disease, etc., etc. So examiner tried a similar thing. Probably you must have not guessed. It is? None of the above is not there? Okay, then, but otherwise all the three are the true statements. Disseminated form is Letter-Suvi, and most common at what age group, doctor? Generally in the case of the neonates to adults it is found, but peak age is between 1 to 3 years, and there is a very good response to the radiotherapy is what need to be remembered. Then option D, which you are telling, is the correct answer. Patch is basically a delayed hypersensitivity like this. Prick test is basically about immediate hypersensitivity is what has to be remembered. If there is a macronodular cirrhosis, generally it is a viral hepatitis which is the most common etiological factor which had been implicated. Then which agent is given orally? In fact, all the three agents can be given both intravenously and also orally. Mesna oral is there, cytosine oral is there, actinomycin D oral is also there in addition to the intravenous. I don't know what was the fourth option. Just make a note of the fourth option, doctor. So please at the end we will include that. Then cerebellar ataxia can be an adverse effect of which drug? It is the adverse effect of cytosine arabinoxide can lead to the development of cerebellar ataxia. I think this time pharmacology questions are all you know or you don't know, stay or get out kind of a questions. There is not much of pharmacokinetics, volume of distribution, all that Einstein level questions are not there. They are all various emitter toxicity, etc., etc., like kind of questions. Cisplatin has the highest amount of the emetic potential. Then there is another previous question, doctor, all India question. Cephalosporins, cefoxitin, cefutitan, clindamycin, metronidazole, they are all anti-anaerobic antimicrobials that you need to include if you are handling a diabetic patient. Let us say he has got a skin infection, you want to add one anti-anaerobic agent inevitably, then you can give metronidazole or cefoxitin or cefutitan. Then another traditional question, classification of the anti-neoplastics which are anti-metabolites, which are alkylating in nature, every time asked. So nitrogen mustards, nitrosoureas, alkyl sulfonates, they are all different alkylating agents. Cyclophosphamide is a nitrogen mustard, melphalan, chlorambucil, carmustine, streptozocin, busulfan, they are all the examples of alkylating agents. Do you use thalidomide for HIV neuropathy? No. How do you treat then the HIV neuropathy? Antidepressants, anticonvulsants, antiarrhythmics, they control the neuropathic pain in the case of HIV neuropathy, which is characterized by a distal painful sensorimotor polyneuropathy is the most common pattern of the HIV associated neuropathy is what you need to basically remember. ACE inhibitors, if you combine with diuretics first time, what will happen? First dose hypotension will occur, just like prazosin also is associated with prazosin with postural hypotension. So to avoid the first dose hypotension with ACE inhibitors, don't combine them first time with diuretics. Otherwise in long term you can combine, no problem. Is there any advantage of giving diuretics in a hypertensive patient, doctor? What is the great advantage? Any antihypertensive basically, why will it fail? Non-compliance of patient, of course, keep it aside. He won't listen to your advice. Second is fluid retention, correct. Fluid retention of any antihypertensive is the main reason why they fail. So combine any antihypertensive with diuretic, it become more effective antihypertensive in clinical practice also. Now let us talk about tolozolene. Tolozolene is a competitive alpha adrenergic receptor antagonist and it is a vasodilator in order to induce vasodilatation. What is pharmacovigilance, doctor? What do? They try to check for the safety of the drugs, monitor the long term and short term adverse effects. That is the main purpose of pharmacovigilance. Then I am searching and waiting for this question. Rituximab, one or the other MAB, monoclonal antibody is a definite question in the entrance. So which cancer do we use rituximab? It is a chimeric monoclonal antibody against the epidermal growth factor receptor, which is used in the colorectal cancer, which is metastatic, and head and neck cancer is what need to be remembered. Emidaron side effects is a general question, every time it is asked. So it lead to corneal microdeposits, hyperpigmentation. Are you able to see the hyperpigmentation on the ear? On the ear? Good. Then interstitial lung disease can occur in emidaron takers. Hypo and both hyperthyroidism can occur in the case of the emidaron. Then this kind of deposition on the cornea called as cornea verticillata, called vertex keratopathy, is one of the side effects of the emidaron. And there can be a blue-gray discoloration of the skin, which you are able to see here, is another classical feature of the emidaron. What makes the physiological dead space increased? Basically, artificial airways, if you place it, it will decrease the dead space, not increase it, is what need to be remembered. What is the purpose of auditory pathway? It is for localizing the sound from where it is coming from. Is mainly the listener's ability to localize is because of a beautiful somatic, because of a topographic arrangement of the auditory cortex is what need to be remembered. Now let us talk about the ovulatory phase of, during ovulation what happens to the inhibin, activin. This is one of the common question. Female reproductive physiology and male spermatogenesis. One question invariably comes in any exam. So it is the granulosa cells where there is an aromatization which is occurring, and in the ovarian follicle there is an activin. Activin increases FSH binding and FSH induced aromatization, and it also participates in the androgen synthesis, enhancing LH action on the ovary and testis. That is a main function. Whereas if you take the inhibin, inhibin in contrary will inhibit the FSH production, and you have inhibin B and inhibin A. Inhibin B is the one which will peak in the early to mid follicular phase and second peak at the time of ovulation. Naturally, no. Until when do you require FSH? Until ovulation you require FSH because follicle should grow. Post ovulation do you require FSH? Not required. So who will tell not required? It is the inhibin which will peak at the time of the ovulation which will tell, and that will make FSH production to become stopped, is what need to be remembered. Now what is the effect of somatomedin? Somatomedin is the mediator of the growth hormones effects. There is a somatomedin A, B and C. Somatomedin A is also called as the insulin like growth factor 2 and somatomedin C is called insulin like growth factor 1. Basically what is the effect of them? What is the effect of growth hormone? First of all, growth hormone has a dual effects. It has an anti-insulin effect, it also has a pro-insulin effect. Now let us examine. The anti-insulin effect of growth hormone is mainly its lipolytic effect on the adipose tissue, and there is a suppression of glycolysis and stimulation of gluconeogenesis. All these are fundamentally makes growth hormone to lead to hyperglycemic state. Whereas the insulin like effects of the growth hormone are mainly mediated by its somatomedin, and that way somatomedin is also called the insulin like growth factor. So out of this Gluconeogenesis and lipolysis are fundamentally what, doctor? They are anti-insulin effects which are directly by growth hormone. Whereas the third effect, glucose intake by the cell, is basically pro-insulin like effect which is mediated by the somatomedin, not directly by the growth hormone, is what need to be fundamentally understood. Vestibular nerves nucleus is the one which maintains our equilibrium. Where does capacitance of the sperms takes place? What do you mean by capacitance? Summer swimming classes. The sperm need to learn how to swim across the cervical mucosa. So that ability for the sperm to do basically comes while it is being stored in the epididymis, and final maturation comes only after it enters the female reproductive tract. But epididymis is the initial phase where basic training, mock tests, everything are conducted for the sperm. Now let us go to the muscle spindle. Muscle spindle has got the sensory receptors within the belly of the muscle which basically detect the changes in the length of the muscle, is the main function of muscle spindle. So a lot of questions come on what is 1A afferent, etc., etc. I think this session is too short to talk so many. Now what is the main function of spinocerebellar tract? Basically spinocerebellar tract will be the connecting link between the muscle spindles which are providing proprioception and the cerebellum, because cerebellum is like the king Dhritarashtra who is blind. It need to get from periphery what is happening around. So all the proprioception is brought to cerebellum by spinocerebellar tract. Similarly, there is a vestibulocerebellar tract which also brings what is happening with the help of the ears. So what is the main function finally for the cerebellum? Cerebellum is not even king Dhritarashtra. King Dhritarashtra is cerebral cortex. He plans something and somebody should fine tune it. So that is the reason it is a smooth movement and coordination of the movement by the cerebellum occurs, and for the fine adjustment it requires to get information from periphery, and for that this spinocerebellar tract basically will help. So it is not for the planning of the movement, rather for the smoothening of a planned movement which is done by the cerebral cortex. Smoothening is done by cerebellum with the help of the peripheral proprioceptive information brought by the spinocerebellar tract is what you need to basically remember. Now let us talk about the potassium ions. Where are they maximum? I have gone through all my physiology books after a long time about this potassium story. Actually potassium, only part of GIT where it is actively secreted into the lumen is where? Everywhere it is absorbed, but only one part of the GIT it is secreted into the lumen, colon. But I didn't get a direct reference of exact concentration values of the potassium in various places, because the only place where it is actively secreted rather not being absorbed, not only being absorbed, is colon. Probably that could be the place of maximum concentration. I am not sure. Now let us talk about fetal hemoglobin. Hemoglobin has two opportunities, either it can marry oxygen or 2,3-DPG. If it marries 2,3-DPG, it has to divorce oxygen. And why hemoglobin lives and loves fetal hemoglobin with oxygen high affinity? Because it has no receptors for 2,3-DPG. Since 2,3-DPG cannot bind with fetal hemoglobin, it has a very high affinity towards the oxygen, is what need to be remembered. Now what is a reflex hallucination in psychiatry? It is one modality of hallucination another. For example, if the patient sees the doctor writing, which is visual, and then he feels that somebody is writing across his stomach, tactile. It's a great opportunity, right? So only thing is you have to see and then feel it. You must be lucky enough to have that hallucination. So it is also called synesthesia fundamentally. Formication and delusion of persecution. What do you mean by persecution, doctor? Somebody is going to conspire against me, poison me, about to kill me, kind of a feelings. So formication means a feeling that worms are crawling on my body. So the both of them are typically seen in the case of the amphetamine substance abuse. Traditional question of the examiner. Then mental retardation, what therapy do we use? It is the cognition enhancement, not management or a modification. First of all, cognition itself, learning itself is impaired in those who are mentally retarded. Then with regard to the hallucination, what is it? Hallucination is an inner subjective, it is basically a inner subjective feeling. In the absence of stimuli it occurs, it is very vivid and it is located in the external objective space, all the hallucinations that occur, not into the inner subjective area. So I think ideally our answer should be A, not into the inner, rather to the external objective space where all the hallucinations, the vivid feelings are basically located. A young woman with a repetitive history of eating followed by purging. Another traditional question on bulimia versus purging disorder versus anorexia, how do you differentiate? So it is an example of the bulimia nervosa and self-induced vomiting, etc., etc. will be the problems. Opioid withdrawal, one of the top 46 topics in psychiatry, which I will give you the list, is substance abuse, on which inevitably questions come. So we do not use disulfiram, which is used generally in alcohol. Clonidine, buprenorphine very much are used in the case of the methadone, they are all used in the case of the heroin withdrawal. Odontoid view, where do you see? Is it a traditional question? Definitely. Cervical spine injuries is a traditional question in radiology. What are the various cervical spine injuries examiner favoritely asks? Jefferson's fracture, Hangman's fracture, Clay-Chauvel's fracture, everything which we discussed in radiology. So you should be sure that if there is a fracture in C1, C2, it is a odontoid view. Are you able to see the C1, C2? If there is a fracture, we can make out. This view is called the odontoid view, is what need to be remembered. Then the Hounsfield's units, physics in radiology. There are about some 50 questions on physics in radiology, which you have to invariably revise before going to exam. What are alpha waves, gamma waves, which has more penetrating power, what is the principle of CT, MRI, what are the units, etc. So you need to know that it is the electron density which basically decides it. Water has a 0 Hounsfield units and air has minus 1000, bone has greater than plus 1000, white matter has 30, like that various values. Of course, if you are unfortunate, one of the value is given and asked to find out which substance it is. Even if you are a radiologist, you can't answer. Even radiologists will check, maybe this Hounsfield unit corresponds to what, they will pick up a pocket book of Hounsfield units, that is the thing. Then double bubble sign, from the time discovery of, is this question there? It is not a veterans, what you call misfiled question. You know what I mean a veterans misfiled question? Routinely if you are writing entrances, you will try to confuse AIIMS questions with PGI questions while recalling. So I hope that is not happening. Then coming to scurvy. Scurvy changes are generally seen in a growing bone, but adults are already grown. So that is the reason radiologically scurvy signs, Frankel's line, everything, they are very classical on a child's X-ray rather than adult. In adult, of course, all the changes of child's scurvy will be there, except epiphyseal widening will not be there. So skeletal changes are difficultly detected, not easily detected in the case of the adults. Now we find a giant cell in the perivascular area, microglial nodules, even they are found in the case of the HIV, in the case of the brain involvement. Vacuolation is also seen. I do not know what were the other two options given. You can just make a note of the other two options to fill up the incomplete work. Stereotactic surgery is what? Remote control. You use one linear accelerator, you will be using protons for it, you will use a gamma knife. Gamma knife is a favorite question of the examiner. Routinely lot of questions come. So you must be sure on it. Now the functional areas in the brain, in the cerebral cortex are all arranged Brodmann areas in a vertical manner. Pilocytic astrocytoma, let us answer this question. This one MRI will help you to answer all this question. Is it in posterior fossa or anterior fossa, doctor, this tumor? Posterior fossa. Then of course looking at it you can't decide prognosis, very difficult. What is the common mistake done by radiologists? They put an X-ray and say this patient presenting with fever. Can you see fever in X-ray? You can't, right? So in a radiology presentation, clinical features are unacceptable, but in a clinical presentation, radiological features are acceptable. Only thing is you should not do a mistake of presenting a case by saying this patient came with a space occupying lesion in the brain. If you say examiner will have a congestive heart failure, he will say first what did patient tell you, doctor, tell me that. No, he came with one MRI, he asked me in the casualty that doctor I have some problem, brain tumor. So initially we start presenting like that the cases, right. So then after that we start presenting them as well nourished, well polished, well groomed, then it goes in a very routine manner, and finally we discover why we are telling all this. And examiner 1 will like all this, examiner 2 dislikes it. So finally we must perceive which examiner wants a long story, short story, because there are some examiners who will like directly go to the problem. What problem is there for this patient? X-ray is showing a mass lesion, sir. Come on, tell what is the differential diagnosis. It can be a bronchogenic carcinoma, sir. You are passed, get out. So there can be examiners like that. Another examiner expects you to tell even in a case of pregnancy also well nourished, well polished, early morning had a Colgate toothpaste, there are skin is fine, nails are fine, tooth are fine, everything is fine, I am also fine. So that is the parody. Anyway, now tell me doctor, looking at this MRI, do you like to say it is a child or adult MRI? It's a child's MRI, he looks like a child, right. So it is not seen in 80s, rather it is found in childhood. So generally it is found in the first 2 decades of the life, not in a very extremes of the age, but it has got a good prognosis. So what is the best way to dispose mercury if your thermometer breaks? Nothing, collect safely and reuse it is the principle. Don't acidify, don't bury it, don't combust it, etc., etc. Somebody asked, gave a call and said your mother-in-law passed away, shall we burn her or shall we cremate her or shall we dig her? Then the son-in-law said, oh, this tough lady died, do all the 3 so that she won't come back. So mercury disposal also is like that, don't burn it, rather try to collect safely and reuse. Then what is surveillance for NCD means non-communicable disease factors. It is also called STEPS, which is a previous question in the exam. Basically the WHO stepwise approach is for the surveillance of the non-communicable disease risk factors. Can you give me one example of non-communicable risk factor? Without jogging, continuously reading in the reading room makes you to find waist to hip ratio increased suddenly by the time it is entrance results come, and you find little angina on exertion, even getting on the steps to the exam hall becomes difficult, and in the middle of exam you will sleep. So that phenomena should not happen. When is the PGA exam happening nowadays? Early morning only, same tradition. In our time it used to be all in the evening fog of Chandigarh and all that. So hardly we can see the OMR sheet, where is it located in the early hours, in the winter session. Okay. So let's go to the next question. Association can be made out by the p-value, odds ratio, relative risk, all of them can be able to make out. What was the option 4? Some alpha error, something like that? Alpha error and beta error are more to do with type 1 and type 2 errors, which are more to do with false positives and false negatives. So not with measuring the association. Prevalence is calculated by doing a cross-sectional study. What do you mean by nested case control study, doctor? Nested means very simple. If you do a non-nested case control, like plain dosha, masala dosha. Plain case control means what? These are my 20 cases, these are my 20 controls with this criteria, and I will complete the study on about them. But in nested case control, you will include new case controls into the cohort that were already defined before the start of the study, then it is called nested. So nested is an example not of a retrospective, rather a prospective study. And what is the advantage of a nested case control? Nested case control can reduce the recall bias and temporal ambiguity which is there in the case control, and unlike what is the advantage over cohort study, it will reduce the cost and save the time which is very high in the case of the cohort study. Now what is a confounding factor basically? Somebody got, what is the best rank this time we got? Second rank in state MD entrance. We are advertising that, our new advertisement is, if you want to get first rank, don't join us. But if you want second rank, fourth rank, sixth rank, eighth rank or any other ranks, top 70 in the first 100, join us. So there are new propagandas done. But if you really look at it, is there any true association? Having had taken coaching, they got it incidentally. Not having taken coaching also, they might have got it. And probably we were otherwise a incidental confounding factor. Born here to collect money from you in the form of fee, coaching fee, and then print your photographs and become millionaires, right? So that's the reason, very difficult to decide whether true association is there or not. But as Mao rightly said, black or white, whatever which fits you the best. Somebody say, I read Harrison, got seat. You need not read Harrison. Somebody said, I did not go to coaching, or I went to coaching and got it. It is his own physiology, homeostasis, cardiovascular ejection fraction, which may not be same as what you have. So he may have less affective dysfunction, he has only one boyfriend or one girlfriend, you have multiple. So you can have all the possible other variables. So that's the reason what is best for you. But there are certain universal things which has to be done, whether you prepare from Mars or from Earth. What is that? Revision of all the stock 1400 topics and solving 15,000 questions with discussion. Invariably have to do because entrance is only a repetition. So confounding factors, confounding variable is an extraneous variable and it is related to both dependent and independent variable of the study, and it can lead to a spurious relationship, and to remove it only thing you have to do is matching. So matching is what need to be done. I am not very sure what was the fourth option, but reduction of confounding variable is done more with the matching, and it is unrelated to disease and unequally distributed among the cases and the controls. They are all very much a valid statements. Now a man is taking 20 cigarettes per day, coughing, family suggests quitting, ready to quit, but thinks quitting will make him irritable, and what need to be done? Irritate him by other ways and show that you can become irritated by this also, not by only quitting smoking. So persuasion is one of the persuasion, motivation, education, information, rising morals, health development, organization. Oh, it's all Bhagavad Gita's last chapters in SPM. So generally we don't read that, because without reading all that only we can clear our SPM exam. So for entrance you have to, at least English you must know. A learned behavior which is consistent, permanent, but still liable to change is called as living in a marriage. It is vulnerable to change, but at the same time you learned how to live in a consistent way. So cultural practice is one such out of all. Now what do you mean by CDC screening of HIV? Suppose if I pass a resolution through parliament stating that everybody above 20 should get checked with HIV, is it permitted? No. It's called, what is permitted is opt-out screening. Opt-out screening means test is performed and patient can elect or decline or defer whether he want to be tested or not, which is called opt-out screening, is what the CDC has recommended, is what need to be remembered, which measures the extent to which a person says the thing is right. Once more, it's more to do with English. I am not sure what was there in examiner's mind. I'll quickly go to the surgery questions. Sister Joseph Mary nodule, where do you find? Bailey Love says you find in everything: gastric cancer, colonic cancer, pancreatic cancer, uterine cancer, etc., etc. All of them are incidentally there over here. Is there any question on except about? No, it is given like that. So good, you have all the four become correct. Only if you left the question, that is a unfortunate experience. Then what is not a pre-malignant lesion of the esophagus? We need to remember that caustic burn, diverticular rarely have a pre-malignant tendency. Human papilloma virus, but not mediastinal fibrosis, is what need to be remembered. What do you mean by penetrating neck trauma? Very simple. The platysma is like a wonderful filter or rather a armor, if there is any injury violating the platysmal layer of the neck, then it is defined as a penetrating injury to the neck, where a lot of vital structures can become injured. Colloidal cyst is a times immemorial topic for entrance, but it is not the type 2, rather type 1 cysts which are more common, represent 80 to 90% of colloidal cysts, and excision, surgical excision is considered to be the treatment of choice. If you take the vasa previa, caesarean section emergency is indicated, and the incidence is 1 in 1275 to 1 in 8333. So your 1 in 1500 falls into that, and basically if you don't diagnose it properly, it can lead to a 20% of perinatal deaths if it is not well diagnosed. So thanks for a patient listening and the contribution of questions, and for those who took the exam, I wish good luck, and for those who are in housemanship, we welcome you to once more take part, one more year of fight to finally see a similar incident in May 2010.